So thank you all for coming tonight. My name is Jason Browder. I'm an internal medicine physician. And for those of you that don't know what that means, it's a very ramped up name for what I actually do. I'm adult primary care, so I don't deal with children. I don't deal with obstetrics. And the osteopathic portion, you notice it's not MD here, it's CO, and we'll get into why that is as we go through the treatment or go through the lecture. But we're going to talk about low back pain, specifically the causes, treatment, and philosophy of care. So here's our lecture outline: the philosophy of care, the causes, anatomy, and treatments. And I apologize for this because I like to talk more than I like to read when I have these slides up. But there's no way to put this better than it's been put. So osteopathic physicians, there are two types of fully licensed physicians in the United States. There's osteopathic physicians, and then there's medical doctors. Osteopathic physicians are trained exactly like medical doctors, except we also receive training in musculoskeletal care, specifically manual medicine, manipulation, kind of like what a chiropractor does. And then the philosophy of care that we provide is distilled down to these four tenets that I'm about to show you here. And so the body as a functional unit represents a dynamic combination of body, mind, and spirit. That's the first one. The second, the body is capable of self-regulation, self-healing, and self-health maintenance. We don't often think about this as physicians, but we take a lot of credit for stuff we don't do, right? I'm the doctor, I suture you back together, and I healed you. Well, what happens in reality is you put the two layers of tissue back together, and then the body pulls them together and keeps them together, and then you remove the sutures at the proper time. When we give antibiotics, typically they're not bactericidal, right? They just retard bacterial growth and give your immune system to catch up and kill it. So that makes obviously a lot of sense. Otherwise, when we got sick, we just died from infections. Finally, structure and function are reciprocally interrelated. And what that means is if you look at an organ, a bone, some part of the body, and study it, you'll understand what its function is. And that becomes important when we're doing manipulation and determining how we treat things, when we're doing injections and understanding why things are the way they are. And then finally, your treatment should be rationalized on these first three principles. Now, if you were to ask an osteopathic physician, other than myself and maybe my partner, what are the four tenets of osteopathic medicine? I'd be very interested to see how many of them could actually recite that or know what they are. And if you ask an MD, hey, do you believe in these four things? Most of them will tell you, yes, I do. I believe in all these things. And they just didn't know that these were some special osteopathic, creation. So, anatomy and causes. I'm going to go through the main anatomical structures of the low back. All right, so this is not for physicians. This is for typically non-medical providers that this lecture is for. And we're going to show you, based on the structure, how pain presents. And then you're going to see how ambiguous low back pain is. And you'll kind of understand the situation that I'm faced with and other providers when you come in and say, I have pain right here. And I go, well, that doesn't help me that much. And you're about to see why. And we'll see how you get through the muscle down to these layers, and we'll talk about all these structures. We'll talk about ligaments, which are all these in purple. We'll talk about the discs, obviously the bone. Right, here's the inside of the disc here. We'll talk about your nervous system as it goes through here. And then we will get down through the muscles and fascia. And I'll try not to get too anatomically heavy. The idea is to give you an idea of the different structures, an idea how they refer pain or how they present with pain, so that you have an idea when your doctor goes, well, that's not what you think it is, it's this. Or when your doctor says this, maybe they're not exactly correct. Or maybe you think you need an imaging study, and the imaging study doesn't change the way we do things, or why we do things, and the rationale behind that. So first we'll talk about muscles. That's the easiest to understand, right? And so if you take the body and you strip away the skin and the top layer of muscles, you're led with these paraspinal muscles, the intercostal muscles as they come down in the back. You can see that you have these muscles attaching to the top of the crest of the hip here. And then if you dive down into the vertebrae, an individual vertebrae like this is one vertebrae. And you can see all these fine, tiny little muscles in here. And this is important because these are what core muscles are. So you hear, oh, you need the core muscle training. And I say, well, okay, what does that mean? what are those? Because I know what they are, right? Because I read about this stuff and I study this stuff. And so these are your core muscles of your spine. And when I send you to do exercise, which is really the mainstay treatment of low back pain, these are what we're trying to affect. The core muscles also are the rectus abdominis muscles, so your six-pack abs, right? Your quadriceps, and then your glute muscles, okay? So I think this is very interesting because these are different referral pain patterns from muscles, specifically these three in the middle. Do you see the disparity here? These are how people will have a muscle that's affected, and it will present in this referral pain pattern. Do you see the problem that I have when you come in? These all look the friggin' same, right? So you say, I heard right here, and I know this could be three different things just from this, and oh, by the way, look, there's a ligament that refers, the lumbar ligament right there, and then there's other ligaments that refer there. So when you tell me it hurts right there, just from the muscles and the ligaments, right, it doesn't really tell me a whole lot, because feeling from the skin level, going through the skin into the muscle and down through the fascia, you can reproduce the pain and it can refer several areas. As we're going to continue, you'll see that. So obviously you have your bones, you have your intervertebral vertebrae. We're talking about low back pain, so that typically tells me that it's in this area right here. So from the 5 lumbar vertebrae and the pelvis and then the overlying sacrum. Typically when people have a blunt trauma force, like a baseball bat hits their back or something like that, they will have pain right at that level if it's affecting the bone. If they have cancer in their bone, it will typically affect them right at that level. And so when people come in and they say, I have back pain, right? I know I have acute back pain, right? So we like to classify back pain into 2 different ways. We say we have chronic low back pain, right? That's back pain of more than 3 months, or acute low back pain, and we say that's back pain of less than 3 months. I know that 90% of back pain, regardless of what we do, is going to get better within the first 3 months, right? And specifically in the first month. And so when you say, I hurt this, don't I need an x-ray, don't I need an MRI? I go, well, you don't really need that, because I know 90% of the time you're going to get better, regardless of what we do. Now, those people that are outliers and come in after a month and they say, I have back pain right here, I go, I need to get an x-ray to make sure you don't have a fracture, if you don't have an obvious trauma or something like that going on, right? Obviously, if you get in a car wreck, someone hits you in the back with a bat, I'm going to get an x-ray right then. But other than that, I'm going to wait. You could have something weird going on that's not obvious, like a bone cancer or something like that, but that is extremely uncommon when we talk about causes of chronic and acute low back pain. Okay? So I put this slide up here, and I was it was a difficult decision where to put some of these slides, because I put this here to demonstrate this specifically, right? And I had all the slides that are in this presentation are proprietary. I have them made so we can do this presentation and put it on the internet and not have to worry about copyright problems. And so I put this up here because people always come in and they tell me they have sciatica, right? And this is a pet peeve of mine, right? As you'll see when we talk about the other nerves, this is the sciatic nerve, okay? And when we're technically referring to sciatica as a cause of low back pain, you're referring to this nerve is irritated, okay? And this referral pain pattern for this nerve goes down the back of your leg and comes up underneath your foot. It's extremely uncommon. I've seen 3 times in 15 years of practice where this gets compressed and exactly reproduces those symptoms. But people like to call it sciatica, right? And so I refer to it as low back pain, period. I think Dr. Dawson does a whole talk just on this whole misnomer. But just keep that in mind. That's kind of a pet peeve of people who deal with low back pain. You come in, I have sciatica, doc. You go, right. All right, so the other thing that people like to implicate in low back pain are the intervertebral discs, right? And so you can see here's those bones that we were just showing the lumbar spine, right? You can see where they connect here. And in between you have these shock absorbers, right? They help allow a greater range of motion from side-to-side motion, and then also from a vertical compression standpoint, when you jump, they compress. They're kind of like Nike Air shocks, right? And that's what they are. People like to say, oh, I have a torn disc, I have a bulging disc, and that's the cause of my pain. And I kind of roll my eyes again, because I know from studies that this is the cause of 5% of low back pain. 5%, and that is it. Now we know that the disc is causing a problem, or that typically some structure is causing a problem around the area of the disc and around the area of the spinal cord, right? If this happens, you get a ruptured disc. And you can see here, it's compressing a nerve. And I know the typical referral pain patterns of the nerves, especially in the lumbar spine, and that's on the next set. But this is what you'll get. You'll get a typical reproduction of pain, either something's hitting that nerve. But for a disc to do this is not that common. You have to have a pretty bad trauma or a pretty weak low back. The trick with these discs is when they're injured or irritated, they can refer up one or two levels. You understand what I mean by that? So you can have a disc down here that refers pain up to here, or it refers down 2 levels. So it can refer up or down a couple levels, and it's very hard to tell. You'd almost have to have someone put a needle in here, which is like a discogram or a disc block, and inject anesthetic into this to find out if that's the cause. Well, I don't personally want anyone going all the way through my skin level, about 2 to 3 inches, probably 3 to 4 on average, to get down to this level, past my spinal cord, right? Dr. Dawson does injections like that, but I don't. So when people tell me they have disc pain, I kind of roll my eyes, as you can see, because it's just not that common. The other thing you should know about discs is they get, I'm sorry, I'm losing my train of thought here. At any rate, just understand about discs, they're not a very common cause of low back pain. Oh, I'm sorry. So here's where I was going with that. There was a study done on truck drivers, and the number's not important, but 50% of the truck drivers had chronic low back pain, right? And 50% did not. And so an MRI was done on all of these people. And when it was done, 50% of the people had bulging discs, right? And 50% did not. So you can imagine that 50% of the people without pain had bulging discs and had no symptoms of it. So when people see on their MRIs, I have a bulging disc, again, I go, is that the cause of the pain or not? I have to stick a needle in there and inject, and it can refer up and down 2 levels. So I'm thinking to myself, is this causing that or is that not? Is that just a red herring misleading the diagnosis that, or the cause of the diagnosis? A lot of people will say that discs are the backup system for failed low back architecture, like muscles, ligaments, tendons, right? That they're the backup system for that. Okay? So here we're getting into nerves. Again, here's our discs. And you can see that disc is compressing that nerve, and that will send a referral pain pattern that is pretty typical, right? And so chronic low back pain that comes to the knee or above is typically not hitting one of these nerve roots, L4, L5, or the S1 nerve root, right? It's caused by a referred pain from one of those other causes, like ligaments, fascia, stuff like that. If it goes down past the knee, then you got my attention. And I start thinking, which one of these pain patterns is it correlating to? Because you'll get pain in a very stereotypical pattern, down to the front of the leg, or down to the lateral aspect of the foot, out to the outer aspect, or down to the great toe. And so it's very characteristic if it's going down that far, especially if it feels like a burning or a fire, or how people typically describe nerve pain, right? So fascia and connective tissue. This is just the stuff that surgeons cut out of the way to get down to the bone and the ligaments, and they never think about what is all the connective tissue. But I want you to understand that all the muscles in our body, all the organs in our body are covered by fascia or connective tissue. And that itself can get torn, and it can get torn or revulsed off the bone, such as the sternocleidomastoid here, one of the low back pain muscles, and that in itself will produce its own pain symptoms. And if you thought that the group of 5 patterns that I put up before are non-homogeneous, then, I mean, these have even weirder pain referral patterns. So here's more connective tissue. Again, the interspinous ligament between that, the spinous processes here, right? This refers pretty directly and maybe up or down. I can compress on this using palpatory skills, and I can inject in this area to kind of deaden it. But again, when we do injections, and people will do diagnostic injections, they'll say, I'm going to inject into the epidural space, right? which is that space, that blue space right there. I'm going to inject into that space, and I'm going to deaden your pain. The whole tract they take, taking that needle in there, some of that anesthetic leaks out. So even doing that injection, you're still anesthetizing that whole region, and you don't really know what the cause of the pain is. So that's the trick, isn't it, right? You have all these connective tissue, the muscle, fascia, nerves, bones, and you go to deaden an area, and and a lot of those structures will go down, and you don't know the pain generator. That's the trick, is trying to figure out what's causing it. Is there more than one thing, right? And so let's not lose sight of other things, such as psychosocial issues, right? Patients that are psychiatrically ill come in and say, hey, I've got this problem, and you're like, are they just depressed? Do they have a history of rape? I don't know, you know? And you really have to delve into those psychosocial issues. But a lot of people will come in complaining of pelvic pain and low back pain that actually have a history of rape, and you have to kind of ferret that out. You have to try different treatments. You have to ask them these histories, right? Connective tissue disease, right? That's the doctor way of saying rheumatoid arthritis, lupus. Some of these more rare diseases can cause pain, specifically down in the low back. And if you don't treat the underlying cause, right, you don't get good results in treatment. But you have to keep these things in mind, right? Viscerosomatic reflexes, right? I don't think most doctors know what these are. And I'll put a picture up there of what those are here in a second. We'll go in further into that. And then obesity, right? And I forgot to put that up here. But obesity is a huge cause of low back pain and such. In fact, so much so that if you have chronic low back pain, if you lose 10% of your body weight, statistically, it will lower your back pain 50%. So if you weigh 200 pounds and you lose 20 pounds, you will typically cut your back pain by 50%. That's pretty impressive, right? So I put this up here. This is just a big mess, isn't it? But what it is here to show you is you can have chronic low back pain from your internal organs. So this is the part I want you to pay attention to here, okay? And then I want to show you here. Here's sympathetic nervous system, right? That's our fight or flight response. That's what causes you to have the adrenaline rush when a bear jumps out of the bushes and you have to decide to run or not. And so that's what we call our sympathetic nervous system. And then we have our parasympathetic nervous system, which isn't exactly showing up here, that's PNS, right? And so this is your kind of rest or digest. And you're in a balance between these all day, right? But what I want to point out here is that you have all these organs that are under automatic control from these systems. And when they're activated, right, these systems, by these organs, very interesting phenomenon happen. So, has anyone ever seen people have heart attacks and they're grabbing their arm and they're going, I'm having a heart attack, and you're going, why the heck are you grabbing your arm? You're having a heart attack, right? Well, I know the heart has a sympathetic innervation from T1 to 4, right? And so the heart sends a signal to the brain on end pain. And when the brain sends that signal back out, it sends a signal out to T1, 2, 3, and 4, where it came from, right from the heart. I know that the upper extremity is innervated by T1. And what the body can't do is it can't differentiate when it sends that signal out where it sends it. It just sends it out through all of them. And so you get that characteristic arm pain because you get innervation from that, right? Likewise, when you get chronic back pain, right in the middle, people come in and they go, I have this pain right in the middle of my back. Do you have any trauma to the area? No, I can't figure it out. And I go, do you have acid reflux? And they go, why, I do. I go, it's probably from that. And I get this referral all day long because the esophagus is innervated by T2A. And what happens is they get a reflux of acid up into the esophagus spasms, and it's a chemical burn. And what happens is, when that happens, it sends a pain signal. It comes back out, T2 to 8, and all the paraspinal muscles, all those little muscles I was showing you at the beginning, they all tighten and lock down. And they might even get a little scoliotic, and it may last 5 to 7 days. And they can't figure out why is that. And I go, well, what we need to do here is see if we can put you on acid reduction medicine and see if that back pain goes away. And it would blow your mind how many times that works, right? So all of these organs can cause characteristical changes in the back. And if you don't ask the right questions, if you don't know what these causes are, then you end up going down the wrong path. Okay, so now we're going to talk about treatments, and this is where it gets kind of fun. I've already kind of alluded to some of these. Right, we're going to talk about the conventional ones. Right? When we talk about conventional treatments, we talk about standard of care. And what standard of care means is, what is the normal things people do that treat low back pain in this Newport News, Hampton Roads area, right? Because it may not be the same out on the West Coast, right? They have different treatment things. A lot more people practice like I do on the West Coast than they do around here. So some of the stuff I do is considered not standard of care. Not that it's bad medicine, but it's just not. So keep in mind when we talk about these things, conventional and then alternative, right? Because I do both of these things, all right? And again, I emphasize, the key is trying to figure out what's causing the problem. Is it those viscerosomatic reflexes? Is it something else going on? Do you have torn muscles and fascia? Do you have psychiatric illness or rheumatoid arthritis? That is the key in figuring all of this out. Right, so here are conventional treatments. Oral medicines, such as anti-inflammatories. This is Aleve, ibuprofen. You could consider aspirin in this category, although I would know that it technically goes in muscle relaxers, such as Flexeril, Robaxin, Soma. Opioids, we know all about those now, right? And then oral steroids. And so I think under conventional medicine, non-steroidal anti-inflammatories like ibuprofen, naproxen are just handed out like Tic Tacs, right? When I was in the military, they called Motrin vitamin M, right? Go get some vitamin M, you'll be better. There are people that take these every day for chronic pain. And the statistic of if you take these medicines every day for back pain, 1 in 500 people will die in that year. These are available over the counter, and people don't know that. If you take more than 2 kilograms of ibuprofen in your lifetime, your chances of chronic kidney disease go up. So I tell people not to take these willy-nilly, right? Because there are bigger consequences that they may not be aware of, right? Muscle relaxers. One of my favorite memories as a medical student was my buddy was renting a room from a lady, and she came and she said, "You guys are medical students, can you help me?" And I said, "Well, maybe." And she came in and she said, "I've got some back pain, I was doing some exercise and I hurt my back, and you take a look at it." And I'm a second-year medical student, right? What do I know, right? But I'm trained in all these osteopathic things, right, that we're going to go into. And so we said, "Well, why don't you go see your doctor?" She said, "Well, I went and saw my nephew. He's a new cardiothoracic surgeon in town, and he prescribed me Flexeril, and I can't take it." And I said, "Why not?" She said, "Because I was on my way home, and I had taken this at the drugstore, and I felt like I had drank a 6-pack of beer, and I had to pull off the road because I was intoxicated." And so imagine that. You don't tell your patient that, and they take it and they go to work, and they're intoxicated at work. The implications of that, medically, legally, for their ability to maintain their work, it's a big deal. And then opioids, right? We have the opioid epidemic. And I'll tell you, I kind of heard this, and I got really tired of hearing about it on the news, and then I heard a statistic. 75% of people that become opioid addicts begin getting prescriptions from their physician. 75% start out getting prescriptions from their physician. And I heard that, and I was like, man, you internally always wonder and second guess yourself, did I turn someone into a drug addict? And I'd say 75% of drug addicts started out with their doctors. So we are doing that to people. There's a difference between opioids and opiates, right? Opioids are the whole class of all the medicines that stimulate the opiate receptor. Opiates are things such as morphine, anything from kind of the poppy extract, right? So morphine, codeine, stuff like that. So when we're talking about treating chronic pain, people will have codeine allergies and stuff, and we know that they're going to have also other morphine allergies, codeine allergies, all that stuff that comes from the poppy, right? And then, of course, we have oral steroids, right? And oral steroids, when we talk about our inflammatory cascade, it kind of breaks down into 2 different cascades. And anti-inflammatories work on one of those. Oral steroids work at the top. They break inflammation at the very beginning, whether it's oral or intermuscular or epidural. And so the same risks, again, with this, occur with this, but with oral steroids, taken long term, it increases your chances of glaucoma, right? It increases your chances of osteoporosis, high blood pressure, diabetes, all these things. And so while I use all of these, I use them all very judiciously in the back of my head, I'm always thinking, are these the right treatments for what I'm treating? Am I treating the underlying cause? Because if they have lupus or rheumatoid arthritis, they may temporarily want to be on this, but we don't want them to be on it long term, right? Physical therapy, home exercise. This is our mainstay treatment for chronic low back pain. Right? Maybe not acute, but for chronic is home exercise. And convincing people to lose weight and exercise is sometimes challenging. But I have 3 exercises that my patients do. They're 5 to 10 minutes a day. And I have them do that over physical therapy at the beginning to see if it will work. Because physical therapy is expensive. And it can be $100 to $400 depending on modalities that physical therapists use. And a lot of my people can barely afford to come see me. So I try them out on home exercise, right, to strengthen those core muscles that we talked about, to see if that makes a difference, right, in stabilizing them. Trigger point injections. I used to do these very, very readily, and I got trained in my residency to do these until I learned about prolotherapy and some of the other things I do. When we talk about injuries to the back, especially with ligamentous injuries, muscles are a backup system, right? So you injure the ligaments in your low back, those big, thick cables back here. Sorry, we're having to go back here, but I want to drive this point home. These right here. You injure these ligaments, specifically for low back pain. See all these ligaments? These are your sacroiliac ligaments. And for the longest time, people would say, oh, these ligaments they don't move. The sacrum doesn't move between the innominants. Well, we know that it does because I could feel it happening, and so could all the osteopathic physicians before me, and they kind of figured out a way to diagnose this and figured out a way to treat it when the sacrum would slide around in these areas. Well, the problem is when all of this starts failing, right, and you start having weakness and these joints start sliding around, that's when you start having a lot of low back pain. And so what happens is the muscles in the regional area start spasming down. The glutes do. You get referred pain down into the iliotibial band. You'll start getting a spasm of the psoas muscle, right? Because muscles will start spasming if they're overused and overworked many times. Some of them will get weak. We call those phasic muscles, but the ones that spasm are the psoas muscle, some of the glute muscles. And they'll form these trigger points, right? And the doctor will go, I got this. What we're going to do is we're going to do trigger point injections. And we can inject steroid into these. We can inject lidocaine or some other, anesthetic into it. Sometimes I see people injecting Botox into these. And this is important because these muscles are firing off as your backup system for failed ligaments. And so if you're putting Botox into muscles that are supporting unstable joints, you're knocking that system out and making their joints more unstable, right? And it's very important because I've had people come in, they can't hold their neck up any longer, right? They have a whiplash injury and they tear a central ligament back here and they get Botox in their occipital muscles and in the muscles supporting their neck, and now they can't hold their head up because you just took out their backup system, and that lasts 3 months. Oops. Find the underlying cause, right? Steroid injections. Like oral steroids, injectable steroids have their own issues. And when we talk about steroids, there's 2 main types. We talk about anabolic, right? That's what we associate with Arnold Schwarzenegger, right? I'm going to build muscle, I'm going to build up tissue, and then we talk about catabolic ones, the ones that inhibit that inflammatory cascade I was talking about. And what I want you to think about when you think about steroid injections, because I use these, right, in the right circumstances, is that when you inject these into a joint, it may cut the pain, or you do an epidural injection, it may help it, but you also may be destroying the local tissue in the area, right? These break down cartilage. They cause joint instability many times, and they're kind of masking the underlying situation, just like opioids do. These things don't fix problems, right? The steroids we use for pain, Kenalog and some of the other injectables, but what they do is they mask the underlying symptoms, right? And we're trying to fix the underlying problem in low back pain, right? So when people want to use steroid injections doing trigger points, epidurals, you have to ask yourself as a patient, is this going to cause more of a problem down the line, cause this joint to be more unstable, or is it really addressing the underlying problem? I'm not saying these are bad, because sometimes this is all you can do to help someone's pain acutely. You got a pregnant female with a bulging disc, and she's getting that radiating symptom, right? What are you going to do? No one's going to take her to surgery. So you may have to do this to get her out of that situation and decompress that nerve transiently. But if you're just doing this, right, not thinking about what you're doing, following standard of care, not thinking about what the problem is, then you have to really watch out why you're doing this. Doctors or patients will often ask me, why don't insurances cover some of the things that you do? And I go, because either they don't want to cover it, right, or they're following standard of care. And they'll say, well, if some of the stuff they're doing is potentially harming me, why do doctors do it? And I go, because they're getting paid to do it, right? Reimbursement, unfortunately, many things that doctors do and people do follows what they can get paid to do, right? It's a hassle to collect money from people sometimes, especially if it's cash for cash-based things. It's easy to send a bill to the insurance company, right? It's hard to talk to people about all these causes and say, this is why we need to do this. This is why we need to try this. Versus, yeah, I'm just going to give you an epidural. All right, we'll set you up for that in the discussion. So, I'm sorry, radiofrequency ablation. What this does is the nerves that are coming out of your back, right? If you're sending a pain signal down, this basically burns the nerve, okay? So, if you're getting a pain signal, pause up in your back from this picture back here. From these nerves, what you do is you try to burn the sensory portion of the nerve, right? If you burn at this level, you're going to burn the pain, the motor fibers, the sensory fibers. So doctors try to get in there and they try to isolate the nerve roots as they come out past this ganglion and try to burn those nerve roots, right? Unfortunately, as I understand it, you can't always do that. And so sometimes when you do radiofrequency ablation, you burn these nerves, you affect the motor function, right? Well, I already told you that muscle imbalance, right? Being out of shape, that's the most common cause of chronic low back pain, right? That's why exercise is the mainstay treatment. So if you burn the nerve that supplies the muscle atrophies and dies, right? So when someone says, hey, I'm going to get radiofrequency ablation, their pain better be pretty bad, and we better have run through everything before I say, yes, that's a good idea. Does everyone understand that? And then finally, surgery, right? And I think the thing that's important about surgery is this. For low back pain, for chronic low back pain, for surgery, if it's just for pain, if you're not having those radiating nerve symptoms, if it's just for pain, okay? Chronic localized back pain. 1/3 of surgeries will cause improvement. 1/3 will cause no different, and 1/3 the patient will get worse. So you have a 2 out of 3 chance of being worse or no different, paying all that money, going through all the surgery, and you're not any better. That's a pretty poor statistic. If you have a spinal fusion, typically what happens is the surgeon will come in here and he'll take screws and he will put them into the vertebral body at different levels and then connect it with a rod, right, for surgical fusion. And the problem with that is the areas above and below the fusion get worked harder to maintain a similar range of motion. So if I want to look over my shoulder, I'm in traffic, and someone fuses several levels in my neck, then the levels above it have to rotate more, or have to turn my trunk more, and so the areas get worked harder, and people become arthritic within a matter of years at the levels above and below the fusion, right? So there's no free lunch, right? That's why surgery should be a last resort. I always get very leery when I see physicians in our community saying, I'm going to try PT. All right, you did that. You didn't do better. We're going to do an epidural. All right, you're not any better. Time for surgery. And I go, oh my gosh. Because 2/3 of the time, they're not going to get better from their surgery. And the patient doesn't even realize it. All right, they're thinking that the doctors that are taking care of them are altruistic and they're really trying to help them out. Well, sometimes they have force pains. So alternative therapies, right? Cold laser therapy. Has anyone heard of this? Right? Go into PT, they take this fancy machine and they shine this cold laser on you. I hear people go, chiropractors do this quite frequently. This is done in physical therapy. I've been offered to buy one of these machines. When you look up some of these treatments, I'm going to show you, there's no statistical value to them, right? And for cold laser therapy, from what I found, and I researched this stuff last week on Cochrane and Up to Date and a few other resources, this showed no proven benefit. So you go in and you pay for a therapy that has no proven benefit. And that's for long-term chronic low back pain. Ultrasound, right? Now, there's developing things in the field of ultrasound, such as ultrasound that can be focused and dissolve solid tumors, like uterine fibromas and different things like that. And that seems to be promising. However, ultrasound used to concentrate down in muscles, as used in physical therapy, has no proven benefit. Okay? So you might go and pay for this therapy, and there's no proven benefit. Right? TENS, right? These are the devices that you see Shaq advertising on TV, where he puts those little patch on his back, and it's got the battery pack, and it's and you see the little things radiating. Man, that must feel so good. This provides pain relief by cutting the pain sensation, just like that radiofrequency ablation, while you're wearing it. And when you take it off, it does nothing. So you put it on, and it provides pain relief. But then as soon as you take it off, the pain comes right back. And that's how all my patients describe it that get these devices. So I get these things from reps saying, oh, I need a TENS device and all this stuff. And I'm like, well, your pain must be pretty severe. And if you're going to use it at home to relieve your pain in place of opioids, fine. But just understand that this fixes nothing. It cuts the pain signal while you wear it. Okay? TENS is very similar to this. This is where you take acupuncture needles and you put them in the muscles, and then you attach an electrode to it. And this actually works pretty well for acute low back pain, right? Much like acupuncture does, right? Supplements, right? You see these supplements advertised. You see cannabinoid derivatives advertised for chronic low back pain. These are like the new greatest thing, aren't they? They're like a panacea. I see them used for anything from seizures to chronic pain, to migraine, to insomnia. And I think the thing to take home from this lecture is there is promising research being done on cannabinoid derivatives right now. Right? So this is like marijuana minus THC. However, the only evidence that I have found on it is that it improves seizures. Right? So there are certain seizures for which cannabinoids have proven to be benefit. The other thing is this is used as adjuvant therapy in chemotherapy or to certain cancer treatments, specifically breast cancer and stuff like that. But that's still not concrete evidence yet, right? So people come in, and I have a license to prescribe these, right? So people come in, and the main reason I got a license for these is not because I want to treat people with chronic pain with this. It's because I have so many people coming and trying these that if there becomes some social issue like they get raided by the FBI, you can go to jail right now for this. This is a federal crime to have these, unless the laws have recently changed. But the state of Virginia, it's legal, but federally it is not. And so what I did was I applied for this license, and you get this license, and you fill it out for the patient. You say, this patient is trying these for chronic pain, for seizures, or whatever. You document it in your chart. But I know that there's no proven evidence for these. So when people come in and say, what do you think about this? I go, I haven't found one. There's hundreds of these on the market from different manufacturers. No one really has any quality control. They're like vitamins, right? They're like supplements. No one really knows. It really is the wild, wild west of supplements. But that may all change in the future, though.
Does the patient have to get a license too?
So what's supposed to happen is I fill out the form for this, and then the patient goes to the Virginia Health Professionals website, and then they register themselves. And as I understand it, they will get a card, and there are dispensaries that are going to be opening up in the next year or so, and they can take that card and they can go get this. But more or less, it's kind of like a plausible defense should some federal agency arrest you. That you can say, look, I'm prescribed this by my physician, and it may be federally illegal, but this is mandated by a medical health professional. Does that make sense? But in my opinion, this is all the first step toward legalizing medicinal marijuana. They're walking us through the process, getting us psychologically ready for when that happens, right? This is the baby steps. But 30 out of 50 states have medical marijuana legal or recreational, medical and or recreational. So, I mean, it's not far behind. This is what will happen probably in Virginia in the next 5 years, is my guess. And no, I'm not selling pot, so don't worry about it. All right, so biofeedback and mindfulness. What is biofeedback? Biofeedback is when you sit there and you put an electrode on your finger and you start basically trying to regulate your breathing, and you can see on the screen my breathing is changing, and you start calming and relaxing yourself, and you can directly visualize this change happening on the screen. This does have some benefit for chronic low back pain. In fact, there are doctors in the area that try to push their patients towards this because it doesn't involve all the other side effects of the NSAIDs, the opiates, those things. Mindfulness, putting yourself into a meditative state. This also has proven to release muscle tension. And you can do this on your own at home for free. You just have to learn how to do it, right? Acupuncture is beneficial for acute back pain, but not chronic back pain, according to studies, right? And when I say according to studies, what do I mean? So there are direct medical studies that people look at, and they're using them either in comparison to other studies that have been done in the past, and they're saying that there's benefit in this one and not this one. So what this man named Cochran developed was groups of people to get together and look at 500 studies on low back pain, and they evaluate them for chronic low back pain, and they go, we found all these things to be beneficial for chronic low back pain, and these things did not prove. And that's where I'm getting all this information from, right? These people that are the experts in low back pain are saying, these are the things. So it's an expert consensus that these things help or they don't. Now, acupuncture as it's practiced in the U.S. is somewhat different, as I understand it, than it's practiced in Asian countries. People tend to take needles and put them into muscles, right? And apply maybe electricity to them in the U.S. This is under traditional Chinese medicine. It's supposed to be done along energetic lines called meridians, but I don't see many people that actually use that acupuncture as it was originally intended. Manual medicine, right? I do this. This is what we get trained as osteopathic physicians to do. This is what many physical therapists do. This is what chiropractors do, right? That's why I have a big star here. I do that. The difference between what I do and what they do is I'm a fully licensed physician. I can prescribe you medicines. I can do injections. I can do all of these things. None of these people, although they can help you, can do those things. They don't have a complete picture of care. And there are massage therapists that are as good as I am at manipulation, right? And there are chiropractors that are excellent, right? I'm not taking anything away from them. We are trained as osteopathic physicians in about 8 different modalities, right? High velocity, low amplitude. That's the popping and cracking everyone associates with chiropractic. Strain, counter strain, which is shortening muscles to get their fibers to reset. Ligamentous articular strain, muscle energy, and the list goes on and on. But we have a complete ability to treat the whole body using training that we have, from your low back all the way up to your head with manual therapy. Chiropractic is only supposed to be licensed to treat the axial spine, so from here to here. Whereas I'm trained to treat everywhere. Massage therapy, I'm not sure about the extent of their licensure. In physical therapy, I see many of them treated just like I do, with exercise and with manipulation. Regenerative injections, right? This is becoming big. I do specifically these injections with dextrose, right, which is sugar. And everyone says to me, you do sugar injections, isn't sugar placebo? I go, well, yeah, it just depends on what the situation is. And we'll get more into this. There are these other modalities that people will talk about called PRP, or platelet-rich plasma, and then also stem cells. All right, and I'll get more into this right here, because that seems to be a big area of interest. So we talked about the osteopathic manual medicine, how it addresses the entire system. The evidence is so strong for this that it became, in 2010 and 11 guidelines for chronic low back pain, manipulation became standard of care in that. So spinal manipulation became standard of care now, based on this meta-analysis done, right, which is that Cochrane collaboration. And so this is a big deal, because for years we've been learning this stuff. I mean, osteopathy has been around since the late 19th century, so almost 150 years. And here we've been doing all this stuff for all these years, and where's the evidence that it works, right? That's what the medical doctors were asking. Well, here we have it based on all these studies and these reviews. So this is very important professionally for osteopathic physicians. So the sad thing is, of all osteopathic physicians, only about 5% practice the manual medicine on a regular basis, like my partner and I do. 5%, right? Even though they're all trained to do it. It takes practice in keeping up with it. Regenerative injections, right? The dextrose prolotherapy, PRP, and stem cells. And so people will say, why don't you do stem cell injections? Why don't you do PRP, right? The supplies I use to do this, with the syringe, the lidocaine, the anesthetic, the cleaner, all of that costs me about $10. It costs me about $10 to do this. To do PRP the way you're supposed to, there's a kit. That kit costs about $320. So before you even do the injection and add in the whole physician component, $10, $320, and then we have stem cells, right? And stem cells typically cost $2,000. So before you even get into any of it, those are the costs. So when I was first learning this, because I was not trained in residency to do these injections, and I had to try them out, right? I need a patient population that is willing to let me do these injections, these regenerative injections, because I think their joint's unstable, right? Their SI joint is unstable. Because I know that as an osteopathic physician, when I go to diagnose and treat them, every time I see them, it's the same diagnosis, the same side. I think the joint's unstable. I think it's a ligamentous problem. And so I want to inject and see if I can get that joint to regenerate and the ligaments to heal. If I start saying, I'm going to charge you $2,000, I've been doing this for about a month, how many people do you think I'm going to get to do that? Not many, right? How many people in this area are going to pay $300 to $500 for me to do injections on that area without absolutely knowing, versus the cost of this? And dextrose prolotherapy has been around for 70 years, right? There's excellent training programs in it, excellent evidence on low back pain, it being superior with exercise over just exercise alone, and also for knee arthritis, tennis elbow. These things, it's shown superiority to steroids, regular physical therapy, and sham. So this is why I do this. There is clinical evidence to show that this works, okay? Now I will say, when I use this, I try to extend it to other areas where maybe there isn't evidence, and I tell the patients that when that's the situation. There may be no evidence for this. However, the principle still remains the same. We are trying to stimulate the body's healing processes to regenerate tissue to stabilize a joint. So what I typically use is a solution of 15 to 25%, as is recommended by this study group called the Hackett-Himwall Foundation. They are the ones that are nationally that are training physicians in regenerative injections. And they're based out of Madison, Wisconsin, and I've been to the course 3 times. We inject these into the ligaments, tendons, and in the joints. So again, these are unstable because you fell on the ground and injured yourself, and now your sacrum's sliding around, or this ligament specifically, this iliolumbar ligament, is disrupted because of an injury, a whiplash injury from a car wreck. Right? I can do manual medicine 1,000,000 times on this, and I can get it to fix. And I see it all the time. It just slides right back out. But that's where the training as an osteopath who does manual medicine comes in. If I see the same thing over and over and over, I have a general idea of what I'm dealing with. And so I'll do the manipulation, and then the patient will come back and I'll say to them, how much better are you? You know, are you 50% better? Are you 70% better? And they get something really irritated because I really push them, and they'll say, yeah, I'm better. And I'll say, well, how are you better? And I'll say, how is your pain level? How is your function? What can you do you couldn't do? Right? Can you sit in the car for 30 minutes, whereas you could only sit 5 minutes before? You know, are things getting better with what I'm doing? And I really try to be realistic and objective about what they tell me, right? We all like to believe that we're the best doctors in the world and that our patients always get better, and when they don't come back to see me, it's because they're better, right? When in reality, maybe they just didn't get better and they wanted to go see someone else to see if they could offer them anything else. So I get really objective about that, and I ask them, how are you better, are you not better? Because again, I don't know if they're going to get better when I do this because there's so many possible causes of this. And I know doing just the injection in the area locally, it may provide anesthesia to the bone, to the muscle, the ligaments, the fascia, etc., as we went over. But when you inject in the right area, and you call, like for regenerative injections, and you cause an acute inflammatory process, the patient knows it, right? They get pain in the area that's local, and it hurts. And then the cells of inflammation move in there. They lay down a network of tissue for healing. The fibroblasts move in, and they start laying down collagen. And you can see the process timing of this, right? This is time in days here. This is percent response, right? So I know in the first few days, you're going to have pain, right? And what do I not want them to take, right? Anti-inflammatories, aspirin, because we are causing an inflammatory process. We are recreating an injury in the tissue to get them to heal, right? Because I know the body is capable of self-healing and self-regulation, right? Because I'm an osteopath, and that's one of our principles, right? And so I know that if I let them heal, they'll do better. The best example of this is, and everyone's seen this, someone sprains their ankle, right? And they go to their doctor, and they have that big swollen ankle, right? And the doctor goes, hey, standard of care here is we give you anti-inflammatories. And they give them naproxen, right? And their inflammation goes down, and they start to feel better. But studies have shown when you do that, the patient goes back to work faster but has more recurrent sprain. So why is that, right?